Okay, good morning, everyone. The title of my presentation is Can we avoid the loss of bone mineral density 1 year after denosumab discontinuation, and how can we avoid it? And we try to answer to this question with the ReoLaus Bone Project for a rebound effect observational study in Lausanne. Okay, sorry, pictures are allowed. So denosumab increases continuously and significantly the bone mineral density and reduces osteoporotic fracture risk. And even if data shown that we can use denosumab 10 years, the denosumab discontinuation before is a reality. After 24 months of treatment, more than 50% of patients interrupt the denosumab, either for medical indication, like aromatase inhibitor discontinuation or no more osteoporosis on BMD or side effects, and sometimes for patients' wish. And the problem at DMAB discontinuation is a rebound effect, combining a marked increase in bone turnover markers for 2 years, a complete loss of the gain BMD, and in 5 to 7% spontaneous multiple vertebral fractures. So we know that there is a problem, and now we have to understand and to try to interrupt this rebound effect. Medical societies gave recommendations, and they are unanimous. We have to give an anti-resorptive therapy, bisphosphonates, after DMAB discontinuation to control the rebound effect, but we don't know which one, we don't know in what dose, when, and for how long. There is some data with a unique infusion of zoledronate acid. It could only partially preserve the BMD lost after the DMAB discontinuation. And there is cases where they try to give raloxifene, hibandronate, or alendronate after the DMAB discontinuation, and patient expected multiple vertebral fracture. So now we have to try to avoid this rebound effect, and the objective of the ReoLaus study is to follow bone parameters after DMAB discontinuation in 170 patients in Lausanne. To be included, patient needs to have received 1 year of DMAB and to be followed in our center in Lausanne. We collected data about pre-DMAB treatment and post-DMAB treatment strategy, BTM's evolution 1 to 3 months after the last DMAB injection and then regularly. And we look at the BMD evolution every year, once a year. And we look at new osteoporotic fracture. Here, I will report the result of the first 71 patients with 1 year of follow-up. So the 71 patients were post-menopausal women, and they stopped denosumab after 7.7 injections. They were 63 years old, and the BMI was 24. They had less than 1 prevalent fracture per patient before DMAB initiation. 8% were on corticotherapy and 22 on anti-aromatase inhibitors. They had 2 BMD in the same machine. We compared 2 BMDs. The first 6 months before the last DMAB discontinuation, and the second 1 year after the DMAB discontinuation. The mean was 18 months after the DMAB discontinuation. The main results are here. We compared 2 groups. We classified 2 groups. The first groups was loser groups, patients where the DMAB diminution was more than 3.9% on T-score. And the second group, the stable group. We had 30 patients in the loser group and 41 in the stable group. And the main results are, in the loser group, the women were younger at DMAB initiation. The CTX level, the BTM's bone turnover markers level at DMAB initiation was higher they never receive zoledronate treatment before the DMAB initiation. And at DMAB discontinuation, the bone turnover markers was higher in the loser group at 6 months and 12 months after DMAB discontinuation. So our main conclusions are, being younger, having higher BTMs, and not having received zoledronate before DMAB initiation increases the risk of BMD loss 1 year after DMAB discontinuation. And even if a bisphosphonate is prescribed at DMAB discontinuation, we observed a BMD loss when the CTX level is higher. Our results support the use of DMAB in second line after bisphosphonate therapy to restrain the BMD loss at its discontinuation. And our results supports a strategy to maintain the BTM, the CTX, as low as possible after DMAB discontinuation.